I'm trained to practice pharmacy, but when it comes to the practice in Kenya, we have to transform it from a commodity-based practice to a patient-based.
Yes.
So we have to stop looking at pharmacists like they are some
Dealer.
like they're there to control
Yes.
certain things. Of course, it forms part of their role, but the bigger role must be based on the patient care, on the service delivery. The moment we get that right is the moment that we shall now have the whole dynamic aspect of having the patient care looked at as a whole.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari Gitao. Today we'll be talking about the pharmaceutical industry. And no, it's not a bad conversation. It's a very simple conversation because we'll be talking about one, how pharmaceutical industry fits into universal health coverage, but also just going back to the basics, right? I know most people, when they hear pharmaceutical, they think big money, big pharma, and much more. But we have an important guest with us. I'll let her introduce herself and we'll get going.
Okay. Thank you, Diana. My name is Dr. Wairimu Mbogo. I am a pharmacist, 15 years of experience in this industry. So I started off my career in the public sector, that's in government. Then I moved to distributorship, where I did various roles from commercial to regulatory. Then I moved to what you call an East Africa role in a multinational. Then moved now to a bigger multinational where I did various roles. I did regulatory. I was able to do business development, regulatory affairs, and I was also supporting East Africa and English-speaking Sub-Saharan Africa.
The entire continent.
Yes. English-speaking, supporting though.
Yes.
Then back to entrepreneurship, joblessness, entrepreneurship, where now we have to understand the basics of what it is to do business in the pharmaceutical industry, and then also now community pharmacy, where what you'd call a retail pharmacy.
Absolutely. We have the right guests. We absolutely have the right guests who'll give us a view of the supply chain, right?
Yes.
And you forgot to tell us you're running for a huge role.
Yes.
Women in leadership. Yes.
Yes. Women in healthcare. So I believe that I have harnessed good experience, good leadership experience as well within the pharmaceutical industry from a policy perspective. And now I feel ready to run for the president of the Pharmaceutical Society of Kenya. We are praying it happens. If it does, I would be the first female pharmaceutical Society of Kenya president in Kenya.
It will happen. It will happen.
Yes.
We need more ladies in leadership role. We really do. And so maybe let's start with the conference, right? You had a big conference. I saw big names. Maybe tell us a little bit about the conference. What was the theme? What were sort of some of the action points that came in, and who are the big names that came?
So we had the conference last week, which was from the 11th to the 15th of June. The conference was in Mombasa. The theme of the conference, the bigger theme of the conference, was now how pharmacists can leverage data to transform policy, transform patient care, with an aim to guarantee patient safety. If, as you know, the Constitution of Kenya guarantees every Kenyan to the highest standard of health. And for us now, we are looking at how do we guarantee Kenyans the highest standard of pharmaceutical care when it comes to their health. So some of the big names, the CS, our lovely CS was there. She graced our event. So the CS, Miss Susan Nakumincha, and also His Excellency, the Vice President of Kenya, Rigathi Gachagua, he came to grace the event. And I know we shall talk about some of the things that were a concern and also a benefit to Kenyans and also to the industry as well.
Absolutely.
Yeah.
I mean, let's start with the basics, right? An average Kenyan, when they walk into a pharmacy, right, they're mostly concerned with either I have a prescription or I have a drug or I am feeling a certain way, because Kenyans tend to first go to their pharmacy before they even go to, a doctor, right? So let's start with the basics. So a chemist, in terms of structure, is usually run, because I understand these are pharmaceutical technologists, these are pharmacists, right? And they have different licenses based on different levels of practice, right? What's that? What's the levels of practice? What does that look like?
Okay. So when it comes to the pharma sector, so we have the pharmaceutical technologist, who is a diploma holder in pharmacy, and then now we have the pharmacist, who is a degree holder in pharmacy. So from a branding perspective, today I will teach Kenyans that the pharmacy with a green cross, if you look at pharmacies, you'll notice that some have green crosses and some have blue crosses. So the pharmacy with a green cross has a pharmacist.
Okay.
The pharmacy with a blue cross has a pharmaceutical technologist as the in charge or as the overall. So what we have done and what the Pharmacy and Poisons Board is looking to do is they are now looking to define now levels of practice, because these two categories should not ideally practice at the same level, because looking at the complexities of what healthcare looks like today, you need better patient outcomes. That is the goal of the physician or the medical doctor. So a pharmacist is better trained or has a higher level of training than a pharmaceutical technologist. And now, yes,
they are trained on more.
Yes, they are trained on more.
Oh, yes,
it's the same way a medical officer would be at a higher level of qualification than a clinical officer.
Absolutely.
And the specialist is now at a higher level qualification than the medical officer.
I
and
cannot do a heart surgery.
Of course. Yes. And then there's a hierarchy around that. To be honest, our industry has not had that, and there has been challenges implementing that. But as pharmacists, we feel that it's about time we did that to secure patient safety and public safety when it comes to medicines, because even His Excellency Rigathi Gachagua, when he came for the conference, there are some concerns he raised around our industry that can easily be cured by just having specific levels of practice. So when we say levels of practice, we're expecting that now the pharmacist we expect now from a medicines perspective that we will have scheduling of medicines. If you look at other jurisdictions, if you look at other countries, we have what you call the OTC medicines, which are even also found in supermarkets at lower quantities, which is something we may need to look at also in this country. Then we have the pharmacy-only medicines, which now are at a different category and now can be handled by the pharmaceutical technologist or the technician. And then now we go to the pharmacist-only medication, and then now we go to the highest category, which has controlled substances. So the pharmacist is able to deal with all the categories of medicines, and they can be in charge of them all. And now the pharmaceutical technologist would now be left to the pharmacy only and the OTC. So that creates some level of security within the supply chain and some level of responsibility and control as to who is managing which drugs where. From a patient perspective, it's also now from an adverse drug reaction, compliance perspective. How are we communicating back to our physicians on how our patients are doing? Because everything now is collaborative, as you know.
Absolutely.
We are now looking at multidisciplinary teams managing one patient and ensuring that they have the best outcomes out of their condition. So we are hoping that we'll have the good pharmaceutical practice guidelines out soon. that now will define that space and what a pharmacist can do and what the pharmaceutical technologies should do and who should be in control of what where they are not available. And that doesn't only work for retail, it should also now work even at the hospital level. And the government now is very keen on primary health care, where now we are now looking at if there's a level 1 and 2 hospital that does not have a pharmacist, how does that structure look like and who manages it? We have sub-county pharmacists who can then now support now the structures in there to make sure that the right thing is actually being done for the patient. Yeah.
Thank you. I mean, that sort of leads to I was going to come at you with a question around, we see a lot of gaps within the system, but we always forget that, a lot of the issues or the gaps we see is a factor of, regulation, but also definition, right?
Yes.
Because as you said, it is there categories. There's a schedule, right? Certain drugs can be handled at a certain level versus another, and it's not so much based on the drugs themselves, it's based on the training, right? So then if a pharmacist has the knowledge, has the experience of handling this, and going back to what you said, patient outcomes, a pharmacist is in a position to look at the entire health journey and say, okay, fine, based on this patient's experience, maybe this is how, as part of the team, then we're able to handle the patient. So it's not just a factor of just the drugs as a commodity, right? Because I think for a long time we've been looking at pharmaceutical industry as it's this drugs, right? And then the other conversation becomes this is the negative image around that, right? So we've never really looked at it from a systems perspective, from a practice perspective, right? And it's important that this is the conversation that's coming out, right?
Yes, and for us, and looking into the next generation, or the next frontier, we have. I'm trained as a pharmacist. I didn't do commodity management for 4 or 5 years in school. I'm trained to practice pharmacy, but when it comes to the practice in Kenya, we have to transform it from a commodity-based practice to a patient-based.
Yes.
So we have to stop looking at pharmacists like they're like they're there to control certain things. Of course, it forms part of their role, but the bigger role must be based on the patient care, on the service delivery. The moment we get that right is the moment that we shall now have the whole dynamic aspect of having the patient care looked at as a whole, and we are seeing improvements. We're looking at we know there are hospitals, even government hospitals, like if you go to Naivasha, you'll have the pharmacists being part of your ward round, looking at the different therapies and discussing it with the doctors to make sure that you're getting a good patient experience. If you go to the community setup, we're now looking at a chronic patient in a holistic view, where now we are starting now to educate the patient on the medicines they are on, understanding the side effects, and even having a report that they can take back to the physician when they go back for the clinic, so they are able to have better clarity, a good clarity on what this patient has been going through, especially for those who see the doctor after like 3 months. So with this, we are calling medication therapy management, and if you look, you will see pharmacists now having a private room to do more, to discuss with you medications, to discuss with you reproductive health when it comes to whether it's family planning options. We now have certifications for vaccines. Remember, all these are medicines.
Absolutely.
They're all medicines. It is just that sometimes the administration is different, and we can see that the curriculum now is geared towards a practical-based approach as opposed now to a theory-based approach, because we're dealing with a patient at the end of the day.
Absolutely. I like that. I mean, the question then comes in. Okay, first, even just of looking at some of the best practices across the world, right? Because, I've experienced the NHS system, right? And there are different approaches And we've seen in Kenya, and I feel like this movement is very much driven by the insurance industry, whereby we're trying this pharmacy first model, and there are different iterations of it, right? And sometimes I look at it and say, you know, there's some benefits to it. If you have a pharmacist who's already trained, has the experience to manage, right, certain either minor ailments, it's okay, right? But then what's your view on this? Because it seems to be a back and forth. There's a push sometimes. The Kenya Medical Association doesn't want it. Other people say, you know, these are the dangers. What's your view in terms of that?
I'll be honest. My view, I believe that the concerns that the Kenya Medical Association and the Kenya Medical Practitioners and Dentist Council would have are based around who are these patients finding in the pharmacies. I believe that if they have the guarantee that they are finding a pharmacist, and we should have pharmacists accredited, pharmacies now on the insurance list, I believe they would not really have a challenge. The issue is now where we have, you know, like a population of maybe 15,000, maybe, or another 4,000 pharmacies that don't have pharmacists, and they're not too sure who is actually managing these patients. So I believe it's a conversation that needs to continue. It's a conversation that would be good to move towards what the advanced countries are doing, because the reality is that a pharmacist is trained to do that.
Absolutely.
A pharmacist is trained to manage minor ailments. Even the law right now recognizes that the pharmacist should be able to prescribe for certain ailments. Of course, I'm not going to wake up and decide that tomorrow I'm going to do a CS.
Yeah, of course. Of course not.
I'm not waking up to do that.
Yeah.
We also know our limits. We are better at referring, because we have seen people getting early diagnosis for conditions like cancer, because a pharmacist is able to question earlier. And understand a pattern of a patient earlier, especially when they're coming for things like antacids, like 247. So you can't have a patient with back pain for 3 years and you're just giving them painkillers and you're not referring. So I feel like a pharmacist has that higher notion to refer. But the sad thing is that we don't have too many of them on the ground. And the reason is because the ground sort of became a bit hostile for them to practice, where they felt that, you know, if I don't give the patient an antibiotic, they'll move to the next pharmacy and be given that antibiotic. So it becomes a survival thing where they feel that they have been pushed out. But I believe that the pharmacist and the pharmaceutical technologists can work hand in hand to make sure that they have a good relationship to ensure that the patient comes first. And if someone is not within a certain category to be able to do certain things, and in line even with global best practices, or even regional, let's talk about Tanzania, Uganda, they're very key. They're very keen on who manages what levels of medicine, and that's what we need to ensure that it happens also in Kenya.
Absolutely.
That we say, okay, we have been doing this in the past. These are the risks involved. Let's now try this that is working in other countries and see how then we manage it.
Yeah, absolutely. Yeah. I mean, you can even see the advantage because, as you said, first we can't maybe even produce enough pharmacists in one go. But even if they're there, you know, there's certain systemic factors to be considered. But you can also see the benefit in terms of the collaboration. So it's not pharmacists versus pharmtechs necessarily. Yes. It's about looking at it as a system approach, because then you can see in the same way primary healthcare, it's about you move from level 3 to level 4, level 5, right? So if I require just, as you said, a common, if I have, say, common cold, right? I don't need to be at a level 6 referral hospital. You don't need to be there. You could be handled at a primary healthcare facility that's closer to you, right? But then it comes back to a question around regulation, right? Because as you said, there's what the public understands, and there is a factor around public education and awareness by regulation, because we have seen headlines around number of chemists have been shut down because either they didn't have the papers. We have seen even patients who've come up and said, you know what, I used to go and they'd give me this. As you said, antacids as an example. We've had an oncologist who's come here and said, if you're having heartburn 6-8 times a year, I mean, there's something more. It can't be you're having heartburn, right?
Yeah.
But then all this is, in many ways, a factor of regulation. So give us an understanding of the regulatory environment currently, because I understand it's the Pharmacy and Poisons Board. But then PharmTechs can open chemists, but the pharmacists can... What does that regulatory environment look like?
So the only distinction that the Pharmacy and Poisons Board has done, and they are really, and I want to applaud them because they're putting in a lot of effort to make sure that safety of medicines is actually guaranteed along the chain. This is in line with wanting to achieve a better maturity regulatory status from a WHO perspective. Right now we are marked at maturity level 1 as a regulator.
What's the maturity level? What's that?
So what WHO has a global benchmarking tool where they now check a regulatory or a regulator to see how well they manage their medicines. I would say from manufacturing to the moment the medicine gets into the patient. So they have classified the regulators. So there's the basic, there's the regulator now who does the basic work. Basically they exist and they can, and they can license and they can register medicines. But then now that is maturity level 1 where we are at, where we are considered at. And then now what we're looking to do is get to maturity level 3, which is a more mature health authority that is in control of certain aspects within the supply chain. So it means that from a manufacturing perspective, there you have the right staff, you are licensing the right people, you have some level of transparency, who is doing what, that the qualifications of the people who are doing the manufacturing are actually right. Then now you move now to the distribution aspect, that whoever who you're putting in charge of medicines is actually the right person. Then you go to now to the retail, what you call community, and then you even now go in the hospital, and then now you go even to the patient and what you call pharmacovigilance, where you're looking at now the safety of medicines in the market. The global benchmarking tool, and for the countries that have achieved maturity level 3 in Africa, because we are now, Zimbabwe actually achieved that the other day. We hoped we are going to be next.
Which countries are those?
The countries that have maturity level 3, we have Egypt, we have Tanzania, our neighbor here. Our neighbor has level 3.
Yes.
We have Nigeria, we have Ghana. Who else? We have 5. We have South Africa. And then now Zimbabwe is next. But
Kenya
what
was
is
beaten by Zimbabwe.
But what is common is that there are clear distinctions on who is in charge of what. And the reality is that the pharmacist is the basic qualification, is the basic entry qualification for medicine safety in all these countries. So as a country, we may need now to look at how then do we move to that level, knowing that I don't think we have a shortage of pharmacists in this country.
Okay, good to
we
know.
Don't have. We have jobless ones. We actually have jobless ones, and they are more being produced. They are more coming in for internship. We have more schools, so we are not devoid of qualifications.
Yes.
What I feel could have happened is that the barrier to entry was a bit lower. So many people got into the technology space.
As opposed to pharmacists.
Yes. And now they became many. And now if there's a license, if you can get open a pharmacy after your 3-year registration, then it becomes a good business plan, I believe. Yes. It becomes it's a good deal. It's a good deal. But when it comes now to the safety of the patient, we may need now to restructure it in such a way that we ensure that we are attaining the highest standard of health. So I'll talk about one topic that our vice president is very passionate about.
Absolutely. We are getting there. Yes.
So one of the reasons why I believe the vice president, the VP, would say I will, because he said I will even give you the police force to help you crack down on unlicensed pharmacies. The reason is based on drug use and misuse. And the category that is likely to have that drug use and misuse problem is what now you'd call the Schedule 4, or the highest category of controlled medicines, which are the narcotic, psychotropic, and controlled substances, or the medicines. That is the only reason that they would come to the pharmacies. And we are saying, as pharmacists, let us schedule these medicines. Once we schedule them, we know who's in charge at what chain, and we know which responsibility we are giving to who. So as the Pharmaceutical Society of Kenya, of course, we are self-regulating. We have intrinsic measures inside the Pharmaceutical Society where if you are in float, or you're floating certain principles, just like the doctors with the KMA and everyone, that there's a level of control that we have on these people, and even globally, it is pharmacists who are in control of these medicines. So why can't we start with that? So if, for example, a town like Kiambu, if it has 50 pharmacies, let's assume maybe it has 50 pharmacies, we don't have to have all the 50 of them carrying narcotics and Schedule 3 and 4 medicines. We can have 2.
Yes, I agree.
And we know that those 2 that have pharmacies, because we cannot keep saying that it's an excuse, these are the most people who have the most, the most pharmacies.
Yes, absolutely.
And I'm talking about now pharmacies because that is the patient-facing category of pharmacies that many people interact with, although pharmacists do a lot more behind the scenes. Yeah, but if I was to close this topic, I would say that if we have a town, we cannot now, we don't have to have all the pharmacies selling narcotics.
Yeah, I agree.
If it's a town like Thika, let's have the 2 or 3 pharmacies that have pharmacists selling those narcotics. And then we know that now this is how we are controlling now this playing field or this game. And that way, even the owners, because when a product is coming into the country, especially a controlled product, there's a lot of regulatory measures that are taken until the distributor level. Then now it gets to then now it goes to this lower level, and then things go haywire. Because at that level, even the Pharmacy and Poisons Board has awareness of how much is coming in, how much is being offloaded into the market. But now what we're asking is, can we now go further and now control this other level? And now we have associated responsibility towards it. That way everyone will know there are 5 pharmacies.
It's that system approach that essentially, you know what, if you are suffering from your cough and your cold, you can go to pharmacy A, and then something that needs to be escalated, this pharmacy B, like that, right? So that there's better control. And also, it's not a competition, right?
It's patient safety.
It's
public
patient safety. Absolutely.
Because medicines are poisons. That's what it's called, the Pharmacy and Poisons Board. It's
a good point.
Medicine,
such a good point.
Medicine taken the wrong way is a poison.
Absolutely. And it's also, it eases the congestion, because as you're saying, there are certain things which, let's take reproductive health as an example. Let's take contraceptives. There's no reason why I should queue at a big hospital when I could go to my local, close by, nearby pharmacy and get whatever contraceptive I'm getting, right? We've seen models whereby, and I think it's been introduced in the country, where you potentially would go get your depot without it necessarily being a hassle of going where and where.
I'm trained by the Ministry of Health to actually do that.
Exactly, right?
And counsel a patient, a client, and talk to the whole. We have time. Come, just go to.
We
have time. Come, ask all the questions, and you'll get all the answers.
Absolutely.
All the answers.
Absolutely.
And I think it's good that people know that the pharmacy with the green cross has a pharmacist, and the one with the blue cross has a pharmaceutical technologist, which means even the big brands or the small brands, whichever brand that you will see, that is the regulation that is in place. And I believe the Pharmaceutical Society will be doing more to market or to educate the the public about that aspect, so that people have awareness on who they're finding in a pharmacy.
Absolutely.
And we have also very good pharmaceutical technologists who have good experience, who have done even higher diplomas, and I would say they are well qualified to actually manage certain patients. But it is good that we make that distinction of who is who, because even me, when I go to hospital, I want to know, is it a nurse who's managing my baby? Is it a clinical officer? Is it a medical doctor? Is it a specialist?
Absolutely.
And that clarity now needs now to go down to the pharmacy space, so that we don't blame the wrong people for the wrong things.
We do. We often do. And I mean, a big part of that, I mean, I'm learning. In fact, I'd forgotten about the crosses. So when you mentioned crosses, I was like, oh, yeah, you know. But a big part of that, it's two-way. Yes, there's the regulation element, but there's the education element, right? So that it doesn't appear as if we're against the public interest, right?
Yes.
Because you do hear a lot of people, the reason why they'd go to the chemist first is because, one, it's closest to them. Second, maybe affordability in terms of you going to a hospital, you have to travel, or even just the cost. You know, there are so many dynamics towards it, right? And that's why different approaches and models in terms of how we look at the system holistically. It's not just doctors only. It's not just, you know, hospitals only. It is pharmacists, and a big part is education.
Yes, multidisciplinary teams.
Teams.
Yeah.
When you get elected, you have to come back.
I have to come back.
You have to come back. We have to be part of your platform for education. You know what?
And when I look at you know, everyone has to have a vision. Everyone has to have a vision if they're looking to go into leadership. And my vision is, number one, to ensure that every Kenyan has access to the highest standard of pharmaceutical care. And that now, within that pharmaceutical care, we are recognizing the pharmacist within that platform. That we're not going to have a position called a sub-county pharmacist that is not being held by a pharmacist.
Yes.
Though the position is called sub-county pharmacist.
Yes.
Yeah, that we are going to ensure that there is distinct job description and a profile, even for the people, for the public facing the counties, that there's a distinct job description. And then within that, now we understand where are the gaps. Where are the gaps in terms of, this is the job profile of this person and this is what they're supposed to do. So we have a gap on this, that we are having now more clinical pharmacists seeing patients. You know, we actually have specialists who are clinical pharmacists.
Yes.
And they have done ICU care. Others are dealing with, you know, diabetes and chronic diseases like diabetes and hypertension. Because see, they're medicine based and they're able now to check. There are others who are doing oncology. Actually, an oncologist cannot work without
one.
They cannot work without a pharmacist.
Yeah.
And there are a lot of improvements along the chain to ensure that that pharmaceutical care is actually well looked after. Because if we are not looking after that chain, we now bring in a problem of the supply chain security.
Which we'll have to talk about next time.
And it's good that I mentioned that you know, supply chain security when it comes to pharmaceutical care is very critical. And as a country, we have to make sure that we have the right professionals within our supply chains. Because if you look at in the private sector, who's managing the supply chain, it is pharmacists. But now when we look at our other sectors, we need to question. Who is in that supply chain, who's managing it, and can we do better?
Absolutely.
Yeah.
I mean, it's a complex
system,
right?
And what are the risks? Are
Absolutely.
we wasting? Are we utilizing our money well? Pharmacy is huge.
It's very huge.
Pharmacy is huge.
This one, like, you get elected, we become your education platform, awareness platform. You name it, we're here.
We will educate even athletes
there you
on
go.
the anti-doping list so that they're aware, so they don't go for a cough and then they have to run, then they are given medicine, then they are blacklisted. you know we might be out here maybe I wouldn't
We're
put
blaming
it
the
past
wrong
them,
people. Yes.
that maybe there are few of them who are not doing the right thing.
Yes.
But there is also a percentage of them who maybe got medicine, legitimate medicine. Then they are blacklisted for the wrong reasons.
I mean, you don't know what you don't know.
So there's a lot. There's
Yeah.
a lot. There's a lot that a pharmacist is able to do behind the scenes. But the goal is to ensure patient safety. I think for us is just to make sure that there's that visibility of the pharmacist when it comes now to that patient safety platform.
Yeah,
So that
absolutely.
we ask them. When things go wrong, we have someone to ask.
Absolutely. I mean, focus on outcomes, multidisciplinary team.
Yes.
You're not just around commodities,
Yes.
right?
Yes.
It's a very holistic approach,
Yes.
right? So the next time I meet my pharmacist, I should be like,
Yeah.
absolutely.
Yes.
Glad to have you.
Thank you.
Come again.
Yes, it's a huge topic, and I'm glad that we got to have this conversation because the my manifesto is founded around what we're calling the EPIC model.
Yes.
So we have education as the E, we have policy and advocacy as the P, we have innovation.
Yes.
There are a lot of innovation or innovative things that are happening within our sector, and collaboration. And this is one of the collaborations that could be happening, collaborations with other associations, collaborations with government agencies, and how do we ensure that we're also collaborating with the patient or the people on the ground.
Absolutely.
So epic.
We hear you. It was an epic discussion.
Yes.
Thank you for joining us on the One Health Lens podcast. We'll see you next time.
Thank you.